Hi, I'm Ara Onyeka. Today we'll be discussing on a very important topic, infant HIV prophylaxis. In the previous sections, we looked at um, implementation of the intervention, PMCTC, in order to prevent mother-to-child transmission of HIV. And we looked at early identification and suppression of the viral load to undetectable level, especially during high-risk period. Well, which we identified as one, during the late pregnancy, during the delivery, and postpartum period during breastfeeding. So we looked at suppressing that virus to that level. We have a lesser chance, about less than 5% of transmission of the HIV to the baby. And also looked at certain procedures and precautions that must put into place when conducting delivery of a mother who is HIV positive. And from there, we shall continue today to look at prophylaxis for a baby that is born to a mother who is HIV positive. And then we're going to look at it in two ways. For those babies born to mothers who have low risk, that is, whom the mother HIV viral load is actually low, and to a mother whose HIV viral load is big. So that is high. So that leads us to um, um, high risk. That leads us to babies born to mother that's that is in high risk, and babies born to mothers whose the HIV viral load is low. So that is what we'll be looking at today. So in this section, we're going to look at introduction, which we've done. Then we'll look at NVP, which is nevirapine, drug of HIV among infants. We look at NVP dosing for infant HIV prophylaxis. Then we look at enhanced postnatal prophylaxis, EPNP, for high-risk infants, HEIS, high-risk infant. That is infants born to mother whose the viral load is actually high. Then we'll wrap it up with clotrimazole prophylaxis for HIV-exposed infants. So these are the things we're going to be looking at in this section. First, we're taking the NVP dosing for infants with HIV for HIV prophylaxis. Like we said, NVP is nevirapine. That's a drug used for prophylaxis in HIV among infants. ARV prophylaxis for low-risk infants, LRI, low-risk infant. That is infants born to mother who are HIV positive, but the viral load of the mother is actually on a level of very low. So that we categorize them as infants born to mothers with low risk. So therefore we call them low risk infants. So the drug we use for the prophylaxis, like we said earlier, is nevirapine, NVP. That is a drug we use. So now, what is the dosing like? We use age and weight alongside in giving the drugs based on national guidelines peculiar to our country, Nigeria. From birth, that is when the baby is born, to first 6 weeks of life, that is first a month and 2 weeks. If the baby's weight is less than 2.5 kg, the dose is 10 milligram of nevirapine. If the baby's weight is less than 2.5 kg at birth, the first a month and 2 weeks, that is 6 weeks of life, once the mother has been confirmed to be HIV positive, though a low risk. The nevirapine dosing states that you are going to give that baby 10 milligram or 1 ml of nevirapine daily until the baby is about a month and 2 weeks, that is 6 weeks. But if the baby's weight is up to 2.5 kilogram, the protocol says give 15 milligram of nevirapine once daily. So that is the national guideline for HIV prophylaxis among HIV-exposed infants. That is the dosing. Now, let's look at HIV prophylaxis among infants born to category of mothers whom we call high-risk infants, HEIs. That is, those children that are born to mother whose their HIV viral load is high, or they were not detected early enough, late in the pregnancy, about the time of birth, they were identified to have HIV. They are categorized as high risk exposed infants. And the protocol is known as enhanced postnatal prophylaxis. For enhanced postnatal prophylaxis, EPNP, for high risk infants, HIS, these are infants born to women with established HIV infection who have received, that is, the mother has received less than 4 weeks of antiretroviral treatment at the time of delivery, that the mother has received less than 4 weeks of antiretroviral therapy at the time of delivery. That is the first criteria we use to qualify if a child is HAIS. Or infants born to women with established HIV infection with viral load greater than 1,000 copies per ml in the 4 weeks before delivery. You understand? So we categorize those children born to that mother as HEIS. So what is the dosing like according to the protocol? Because of this high risk, it is recommended that this infant dosing goes beyond 6 weeks of age. And this is considered as special situation. So in their own treatment, in their own prophylaxis, you expect to give ARV, 1, nevirapine, that is used in low risk. You're going to give nevirapine, NVP, and zidovudine, AZT. You're going to give nevirapine and zidovudine for the first 12 weeks of life. For the first 12 weeks of life, you're going to give, that's about 3 months. You're going to place that child on nevirapine and zidovudine for the first 12 weeks of life. Whether they are being fed with breast milk or with infant formulas, you must place them on nevirapine and zidovudine for the first 12 weeks of life. That's what the protocol says. You're going to place the child. Now, also as we did for low-risk infants, where we say give nevirapine 10 ml once daily for the first 6 weeks of life for low-risk infants, based on weight. If the weight is less than 2.5, you give 10 milligram of nevirapine. Please, it's not 10 mil. So you give 10 milligram of nevirapine to that child alongside with 10 milligram of zidovudine. But here you're going to give nevirapine 10 milligram once daily for the first 12 weeks. Then you give 10 milligram again of zidovudine twice daily. Twice daily. So in a day, the child is expected to receive, that infant is expected to receive 10 milligram of nevirapine, maybe in the morning or in the night. Then the infant is expected to also receive 10 milligram of zidovudine in the morning and in the night. Now, for babies with birth weights greater than 2.5 kg, 15 milligram of nevirapine given once daily is recommended. That is around 1.5 mil for suspension. Then, with 15 milligram of zidovudine twice daily, that is the recommended dosing for infants born to high-risk mothers. That is a prophylaxis regimen for them. So the difference between low risk and high risk is the addition of zidovudine. But the birth weight is an indicator of the dosing. If you're upping 10 milligram for children or for infants less than whose body weight is less than 2.5, then 15 milligram for children whose body weight is greater than from 2.5 and above. So that is the protocol for prophylaxis among infants born to either low risk or high risk. That is for the low risk infants, first 6 weeks. Then for the high risk infants, for the high risk infants from birth to 12 weeks. But however, from the birth to 6 weeks first, from when they are given birth to the first 6 weeks of life, you're going to follow that regimen of giving nevirapine 10 milligram once daily and 10 milligrams zidovudine twice daily if their birth weight is less than 2.5 kilogram. But if the birth weight is above 2.5 kilogram, you give 15 milligram nevirapine once daily and 15 milligrams zidovudine twice daily. That is the recommended dose from birth to 6 weeks. But because they are high risk, from 6 weeks to 12 weeks, from 6 weeks to 12 weeks, remember we said from birth to 12 weeks for high risk. But from 6 weeks till 12 weeks, you will be giving that infant 20 milligram of nevirapine daily and 60 milligram of zidovudine daily. That is from 6 weeks to the 12th week for high-risk infants. So expected to give 20 milligram or 2 mil for suspension once daily and 60 milligram, that's 6 mil zidovudine twice daily. Now, the last part of our today's section, cotrimazole prophylaxis for HIV-exposed infants. Cotrimazole, that is Septrin as a brand name. How we prescribe it for infants is part of the prophylaxis for HIV-exposed infants. One, cotrimazole prophylaxis is recommended for HIV-exposed infants from 6 weeks of age. So you are going to introduce cotrimazole from 6 weeks, not from birth. So it is recommended for HIV-exposed infants from 6 weeks of age and should be continued until HIV infection has been excluded by age-appropriate HIV test. That is, from that birth to 6 weeks for low-risk infant, and from birth to 12 weeks, this child is on this prophylaxis with nevirapine and for high risk. By 6th week, you are expected to introduce cotrimazole prophylaxis for that infant. So as this prophylaxis is going on, test is being conducted. So until when the tests have proven that this child does not have HIV, that is when you can stop giving the cotrimazole prophylaxis. So it says that until HIV infection has been excluded by appropriate HIV test, 12 weeks after completing cessation of breastfeeding. So that's when you're going to stop giving cotrimazole prophylaxis. So here is the dosing. For infants below 6 months or 5 kg. Yeah, we're not talking about 6 weeks, remember. For infants below 6 months, for infants below 6 months, or whose weight is less than 5 kg, you are expected to give 120 milligram of cotrimazole daily. That is 1 tablet. Or in suspension, you give 2.5 ml. But if you are giving adult dose, adult strength, at least if you are using septrin that is meant for adults, you are expected to give 1/4 of the tablets. When you break it, 1/4 of the tablet to the infant. Then for infants 6 months to 5 years, or whose weight is 5 to 15 kg, you are going to give 240 milligram daily, or 5 ml of the suspension, or 2 tablets. If you are using adult tablets, that is adult strength, that is a single strength for an adult, you give half of the tablet to that child who is 6 months to 5 years, or whose weight is from 5 to 15 kg. So this is the HIV as recommended in our country, Nigeria, and based on your level as community extension workers and other primary healthcare workers. So this is the dosing for prophylaxis for HIV infection. So let's take a quick look at what we've discussed today. At first, we'll look at ARVs prophylaxis for low-risk infants, and the drug of choice is nevirapine, and is based on the dosing whether the infant is bigger, weighs higher than 2.5 kg or lesser than 2.5 kg. If the child weighs lesser than, you give 10 milligram nevirapine daily. If the child weighs around 2.5 and above, you give 15 milligram once daily. Then for high exposed infants, HEIS, whom we define as infants born to mother with established HIV infection, who has received less than 4 weeks of antiretroviral therapy. The mother received less than 4 weeks of ART treatment before the time of delivery. Or those infants born to mother with established HIV infection with viral load greater than 1,000 copies per ml in 4 weeks before. So when the test was conducted, conducted 4 weeks before delivery, that is a month before delivery, maybe when the mother is 8 months, the test was conducted, and the copies of HIV viral load is around 1,000 per mil. Those child born to that mother is HEIS. Okay. Then it is now recommended that their own dosage should exceed 6 weeks. As such, with the introduction of nevirapine and zidovudine. Nevirapine and zidovudine. Okay. Then, still considering birth weight 2.5, lower or higher. If the baby's weight is around 2.5 up, you give nevirapine 15 milligram once daily and zidovudine 15 milligram twice daily. But if the infant's weight is less than nevirapine, less than 2.5 kg, you give nevirapine 10 ml once daily and then give 10 milligram of zidovudine twice daily. So also you have to introduce cotrimazole prophylaxis, which you are expected to introduce if the child from six weeks, you should be able to introduce according to the recommendations. Be able to introduce it. Then we looked at the high risk exposed infants from birth to 6 weeks, where you introduce 10 or 15 milligrams, depending on the child's birth weight, from birth to 6 weeks. Then from 6 weeks till 12 weeks, you increase the dosing to 20 milligram nevirapine once daily and 60 milligram zidovudine twice daily. Then we wrap it up with cotrimazole prophylaxis for HIV exposed infants, where we looked at introduction of cotrimazole from 6 weeks of age for high risk. So you give this drug based on if the infant is below 6 months, that is anything below 6 months. Once you are introducing cotrimazole, you're going to give that child 120 milligram or 2.5 ml of the suspension. Then if you are using adult strength, you give about 1/4 of the tablet. Then if the child is for 6 months and above, you give 240 milligram daily or 5 ml of the cotrimazole. All this is known as prophylaxis. Thank you. If you have questions, you drop it in the comment section and it will be attended to.